Right. Okay, we get underway. Welcome everyone. This is another of the ITP Support Association's virtual patient group meetings. I long for the day when we can actually meet in person again. Hopefully that's not too far off, but fingers crossed, fingers crossed. I'd just like to introduce the expert we've got with us today is Dr. Catherine Baggott, as many of you will know, from Glasgow Royal Infirmary. I'm also pleased to have Dr. Mrs. Rhonda Anderson as Senior Patient Mentor from the ITP Support Association, and a couple of board members from the association, Mr. Derek Elston and Mr. Anthony Hurd. So if anyone's got any questions they want to kick off, please fire away. Does anyone want to get a question they want to start with? Kay, go ahead, please.
Hi everyone. I'm just wanting to ask, I've been taking Revelade since December, and my count has now gone right up to 451. I just got the count today. So they're stopping my drug and they're going to check me weekly now. So my concern is, obviously, are there going to be any effects of me just getting the drug stopped? And also, am I likely to crash quite dramatically because I'm getting taken off everything, so to speak? I'm just a bit concerned about it.
Sure. So how long have you been on it for?
I went on it just before Christmas time.
Oh yeah, sorry, you did say.
I was up at 75 milligrams. Then they dropped me to 50 a month ago because my count was going up so high. Right.
And how high did it go?
Well, that's the highest today, 451.
Right.
From 12 at the start.
Right. So it's all about finding the right dose, really, isn't it? I mean, I'm not too worried about it being 450, but they're monitoring every week. I mean, if it is going to fall, it generally falls within 2 to 3 weeks.
Right.
And there's various ways of doing it. Some people might give you alternate day, give you 50 milligrams every other day, or some people do stop it, but it probably will fall again. It's difficult to know exactly how quickly it will fall, but monitoring it weekly, at least they'll catch that, because most people fall within 2 to 3 weeks.
Right. And will I have any effects with me just getting the drug stopped? Will I feel anything, or will I be fine? No.
Nah, you shouldn't feel anything at all. I mean, I don't know if you're someone who suffers from tiredness when your platelet count goes down, but no, you won't suffer any ill effect from just stopping it. No.
Right. Okay, that's great. Thanks very much.
It's okay.
Thank you very much, Kay. Any other questions? There must be some. Yeah. Okay, Patricia.
Yeah, actually, this is a comment, and it's a good reason why we have these support groups. About 2 years ago, so I went to a physician. I was about a vascular problem with my leg, and he saw that I had ITP. He says, "Oh, no, you've got to have a splenectomy. That has to be done right away." I said, no. I said, "I'm 60. I said, I can't, I'm not having one." So this proves that doctors, probably in their medical school, they're told what ITP is and they're told you're going to have a splenectomy. But because we as a group meet together, then we probably know a lot more than just the lay doctor. I mean, specialists, they know everything, but the lay doctors don't. And because we have our meetings, we're able to share and let other people know what their physician, their specialist is actually saying. So that's why it's really good that we can actually share, because that's where we get our information from.
Yeah, I think I'd agree with you. I think it's like all specialties. There's lots I don't know about obstetrics or, I don't know, vascular surgery, because every speciality is moving so fast. I mean, 10 years ago, we didn't have romoplostim and L-Trombopag, and 10 years ago, many more people were having splenectomies. So things do change. So someone who was at medical school 15 years ago will think that splenectomy is a very common treatment for ITP, whereas we know that the position on that has very much changed now. And that's another reason, I suppose, that someone like myself and a lot of other haematologists really try to get medical students involved in haematology, because you don't actually get a lot of training in haematology in medical school. And yet, to my mind, it's such an important speciality because every doctor does full blood counts. So yeah, and you're absolutely right. Having patient groups like this, you can all share your experiences and, you know, educate the specialists as well. You know, it's, you know, we really don't know everything, and we also, you know, don't fully understand the patient experience, even though we try to. So yeah, no, I completely agree with what you said.
I think that's absolutely right, Catherine, Patricia. I think you have to be mindful that there is so much information now available on all conditions. The specialists can't know it all. But I know my haematologist, when she was appointed and I went to see her, and I said, well, what do you know about haematology, about ITP? And she said, not a lot, but I know a man who does. So I said, who's that? So she said, Drew Provin. I said, I know Drew very well. And ever since then, we've got on like a house on fire. And in those days, I was living quite happily on a count of 10 until I had a heart bypass 6 years ago. And when they were going to discharge me, the surgeon came and said, oh, you can go home tomorrow. We'll prescribe warfarin for you. No way would I take warfarin. There was an F1 student at the back, and he said, quite right. He said, Mr. Elson can't take warfarin. And this consultant turned on his heels and walked off. But, they didn't prescribe warfarin. So be mindful and be patient with them. They can't know it all.
Well, that's very true. And sorry, if I could just come in here for a moment, because it fits in perfectly, really, with what I was talking to Jack Sansom about today. We had a Zoom meeting, and we're working on a toolkit which is for clinicians and patients, and to enable the patient experience to be better. And you know, if you've got any ideas on that, you know, please tell me, because I'm the only patient on the group, and I think I've got a pretty good idea. But, you know, if people want to tell me, you know, the one thing or the top 3 things that they would have liked to have known when they were first diagnosed with ITP, and how that would have helped them, and how they would like the relationship between the patient and the clinician, regardless of who it is, even if it's like a GP or a nurse at your practice, or the hospital doctor that you've seen, or the CNS, the clinical nurse specialist. You know, what is it that you really want in your early diagnosis? And then as you go on and finding out more about ITP, the implications of it, you know, what do you want in order to be able to live with your long-term condition in as happy and healthy way that you possibly can? So I'll pop my email into the chat. It's also in the Platelet. But I mean, if tonight, as we're talking about things, any of these points come up, if you could, you know, briefly say, then that would be very helpful. So thank you.
Yeah, what Rhonda was just saying, that will be very useful, because the project she's talking about is called the Itp Roundtable Project. That is a result of the patient perception survey we did last year, you know, that many of you would have completed, hopefully. And we're aiming to actually get this, we're calling it a shared decision-making document for patients. We're doing it in conjunction with the ITP Forum. And we're aiming to try and launch it, if we can, during ITP Awareness Week in September. So fingers crossed on that. It will be quite useful for all ITP patients. So I'm amazed no one's come up with a COVID question so far. The last Anthony has. Right, go ahead, Anthony.
Yes, good evening, everyone. And obviously, I knew it wouldn't be long before we got around to COVID, so I've prepared something earlier. And it's about the situation for people like myself and many others who are immune suppressed. I know at the beginning of April, I read one of millions of reports about COVID suggesting that there's something called an Octave trial being undertaken by Birmingham and Glasgow universities, where they are sampling 5,000 people to see what level of protection someone who is immune suppressed might potentially get from the vaccines. So first of all, I just wondered, has there been any sort of further updates on that? I guess probably not, because I haven't seen them. And also, what's the best guess about what level of protection we could possibly expect? Although I know that's not an easy one to come up with. So just a general discussion around that, I guess.
I know some very early works. I'm not an expert in this area at all. I know some early work's been done with the AstraZeneca vaccine. I think it's the AstraZeneca vaccine. I'm sure it is, where people who have cancer and are on chemotherapy, so much stronger immunosuppressive treatment, are having very minimal responses to the first dose of the AstraZeneca vaccine. I don't know the figures definitely, but it was something around about 16% with the first dose. But that's very different to if you're on, if you have something such as ITP and you may be on prednisolone or azathioprine, it's not in the same ballpark. But it's just to give you some idea that there are some people out there who aren't responding, as well as the general public. And who knows? I think it's really important that we find out. I think the thing I would always say about this, though, is this balance of benefits. So you are immunosuppressed, whatever you may be on, prednisolone, azathioprine, mycophenolate, rituximab, you are immunosuppressed, which means you're at increased risk of getting COVID, and if you get it, having a more severe infection. And having 16% protection or 30% protection is better than having zero protection. So we don't know what the protection might be for someone who is on some immunosuppression who doesn't have cancer. It probably isn't as good as the general population, but it's better than not being vaccinated at all. So that is my please get vaccinated speech.
Yeah, absolutely, thoroughly agree. And my guess was that after the second vaccination, you'll probably got increased protection. Yeah. But on that sort of subject and slanting off a bit, I was surprised on the last support group meeting, Professor Newland was saying that one thing perhaps people don't appreciate is that the flu vaccine is only 60% effective, which is quite amazing. And we don't hear things like that enough from the media. We hear a lot of scare stories, and understandably so, but it's nice sometimes to sort of compare and contrast things like effectiveness and that sort of thing against other vaccines. So it's quite interesting. And
that's so true. When they were looking to see when they were looking for the sort of parameters that a vaccine had to meet in terms of efficacy for COVID-19, they're only going to consider vaccines that gave 50% effectiveness. So you were going to be able to pass the finish line, if you like, if you got over 50% effectiveness. So when Pfizer first came out and had 95% effectiveness, it was almost unbelievable, because having effectiveness of greater than 50% is considered good. So yeah, I think we've been amazed at how effective, excuse me, all the vaccines are to date for COVID. And I think you're right, we have to bear that in mind.
Good stuff. Thank you very much, Anthony. There's a question in the chat. It's from Lucy. I've had ITP since diagnosis after pregnancy 16 years ago. My lowest count ever has been 40, never required any treatment except steroids prior to planned major surgery. Should patients with stable ITP have platelets checked on a regular basis? And Lucy is actually a pharmacist by trade.
Okay, so again, that's changed over the years. I think all of us in the ITP world will say it's not platelet count that matters, but it's bleeding symptoms that matter, and also put in their quality of life as well. So if your platelet count is normally 40 and you're having no bleeding symptoms, then I would not be checking your platelet count regularly. I would, we have something in my hospital now called patient-initiated review, which has come along partly because of COVID, but something that we've been starting anyway. Basically sort of saying if you've got ITP or you've had ITP in the past, you may be in complete remission. You may have a platelet count that's greater than 150, or you may be someone who's been off treatment for years but has a platelet count of 80. And I'm putting a lot of those patients, with their agreement onto patient-initiated review, which means you don't get regular appointments, but if you need anything, so you might be having surgery, you might have bleeding symptoms, then we have an open door. You don't have to go through your GP, you just have to call. Because the thing is, if you're going to relapse from your ITP, you're not going to do it the day you come and see me. So we're moving a lot more towards that. People on treatment know they have to come to clinic and we need to keep an eye on them, but others who are stable with lowish counts don't necessarily have to keep coming to see me. And sometimes I worry that it causes anxiety. I have so many people who say to me, oh, I've been worried about coming to the clinic, I've been thinking about my platelet count more than I normally do because I wonder what it's going to be. So I think sometimes bringing people up to appointments isn't necessarily a good thing, as long as they know that we're available if they need us.
Okay, thank you very much.
Can I just come on to that, Mervyn? Catherine, yes, I'd agree entirely with what you say. As I said earlier, having lived with a count of 10 for 15 odd years with no medication, I eventually got down to annual visits to see my consultant, who was very happy because I wasn't bleeding, I was being sensible, and like you say, if anything went wrong, I always had the available success to the hematology department without any problem at all. So I think it's obviously psychological with some people. They like to know they've got a platelet count. So
yeah, as I say, it's very much with the patient's agreement. If they really feel they need that reassurance, then they keep coming to clinic. But certainly I feel much more comfortable with patient initiating the need for clinic rather than me.
Yeah.
Okay, thank you very much. Got one from Joan. I'm assuming, Joan, are you in Ireland? Yeah. Obviously, yeah. Anyway, in Ireland, the AstraZeneca vaccine is only given to the 60 to 69-year-old age group. I have ITP and no spleen. Am I at increased risk of my platelet counts being affected getting this vaccine?
Sure.
There's one for you.
So we're collecting data on new and relapsed ITP with the AstraZeneca, with all COVID vaccines, because we know that ITP can be exacerbated by any vaccine. Was particularly noted with the MMR vaccine. So we are collecting that data. We think that probably the COVID vaccines, all the COVID vaccines, not just the AstraZeneca, probably do. So we know that anyone can relapse with their ITP and anyone can get new ITP. So you're having to look to see what's the baseline that occurs, and are those who are getting the COVID vaccine, is it increased from the baseline we normally see? And we think from preliminary data, it probably is a bit above the baseline we would see. So there probably is a link, but that wouldn't, again, I would still strongly recommend that the vaccine is given to everyone with ITP, particularly if you don't have a spleen. That's even more important. And, to be aware, it might exacerbate my ITP. So if I see any bleeding, contact the hematologist, get checked out. So because it might not be related to the vaccine, it's always very difficult to know. But I would say to anyone who gets any COVID vaccine, if they keep an eye out for any bleeding, and if they get any excessive any bleeding that they don't normally get, is to speak to a hematologist and get a platelet count check.
Yeah, we've actually got a survey going on, and very, very interesting. From the latest survey's got 160 people. We had a previous one with 260, but there's more people when they've had the first dose. The platelet count has gone up than it's gone down. So the ones going up, I can't remember the figures, but it was probably about 15% more went up than went down. So, which is interesting facts, that's going on. So very interesting.
I think the thing is, so we know in pregnant women who are naturally immunosuppressed during pregnancy that we frequently see the platelet count go up in patients, in pregnant women who've got ITP. So that just because, you can see the platelet count down with the vaccine, what vaccines do is they are affecting the immune system. So it's quite possible. I wouldn't surprise me at all if some counts go up and some counts go down and some don't do anything at all. Yeah, it doesn't surprise me. I didn't know that. That was very interesting.
There's quite a few people in the chat just telling us how their count has varied, which is quite good. Any other questions from the group? Deborah.
Hi, I just wanted to ask you, you're talking about romiplastin and eltrombopag. My son was diagnosed 9 months ago and he was 0 at the time, and he was on eltrombopag and went up to the highest dose and even above, and it didn't raise his platelet count over 10. So then he was put on to romiplastin, and at the moment now we're 2 increments away from the end, and his count was 2 this week. And I'm just wondering, if we're at this point with romiplastin, is it likely that it's not going to work now, even though we have 2 increments still to go?
So how long ago was he diagnosed?
9 months.
9 months ago. Okay. And did he go through some steroids to begin with and responded to those? Okay. He's
never been above 10.
So he's not responded to steroids, and then he's not responded to eltrombopag or romiplastin either. So it sounds like his ITP is quite hard to treat. And I suppose, if I'm honest, obviously, I don't know the intricacies of your son's case, but probably if you're not responding at quite high dose of romiplastin, you might not respond at the higher doses either. I think I should put my hand up as well and sort of say I'm not a paediatric hematologist, so I don't deal with children. So my experience, although I meet with paediatric hematologists who treat ITP all the time, I don't actually have that personal experience for a number of years. But in adults, we will try different things. I think the other thing I'd say, it's all about bleeding as well. So if he's having bleeding symptoms, yes, need to treat and see that there's something we can do to get his platelet count up. But if he's not bleeding, then the question is whether we wait and see, because children can, well, anyone, but in particular children can go into a spontaneous remission. Does he have bleeding symptoms?
Not really, but if he bangs himself off anything, and he's 14, so he could be out in the yard at school and everything, and the bruises are horrific. And what happens is that the bruise kind of swells and it bleeds then. And it happened to him last week, and that was Friday, and it's still weeping today. So it hasn't dried up.
So that's why, that is fair enough. 14-year-old boys are going to bump and, fall and all sorts of things. So I can really see why they're sort of, still trying to progress with treatment. So as I say, I'm not a pediatric expert. We would do various things in adults, in adults, we sometimes try both together, romiplastin and eltrombopag. That has been tried. Sometimes we will use something like eltrombopag and romiplastin plus something to suppress the immune system. Now, I'm not certain how keen paediatricians are to suppress the immune system, but again, it's the balance of risk and benefit. So if his quality of life is poor, because you're almost going to have to wrap him up in a bubble to prevent him getting these really big bruises and sort of these swellings, what we might sort of call hematomas, when you get a lot of bleeding under the skin and you get a swelling, then it's all about balancing risk, benefit, quality of life. But I think in answer to your initial question, I think yes, it's worth pursuing higher doses of romiplastin, but it might not work now, and then it's a matter of looking at alternatives, which there definitely are. There definitely are.
And what would your suggestion be for an alternative? Eltrombopag, he was actually on over 100 milligrams of eltrombopag and didn't get past 8. And down the romiplastin, we're kind of with the increments and then back to 2. We kind of had we thought he was great the first week. He went up to 8, and we nearly had a celebration, even though it's such a little difference, and I know it doesn't count. But it was as if his whole immune system then got ready and completely, got rid of the romiplastin. I'm just wondering, what would the next?
So I can only really, one thing I did want to ask you, if it's okay, has he had a bone marrow test?
No.
No. So again, I have to speak from an adult point of view. If I have someone who is not responding to treatment, because adults can have other conditions, this is why it's a bit different in children, which you do have to take what I say from a very much an adult perspective, is that in adults I would do a bone marrow biopsy at this point to make sure I wasn't missing anything else. Because adults can have other bone marrow conditions that present with a low platelet count. It's different in children, but that's something that possibly the paediatric doctors might say at some point. You know, they may be saying, okay, look, if we don't get a high enough platelet count with romiplostim, maybe we need to consider doing a bone marrow just to make sure, you know, this is definitely ITP. But I am speaking more from an adult perspective. But in terms of alternative treatments, when we get patients who are very refractory to treatment, we do try different things. So as I say, putting romiplostim and L-Trombopag together, or using one of those with some immunosuppression, such as azathioprine or mycophenolate. So there are, you probably know about most of the treatments, but you can combine them. So that
and
might
can I ask you about Rituximab? What relation is that in the other two? Is it very different? Would that be another treatment that they would suggest? It's just that mentioned.
So that's an immunosuppressant. So basically the cells that make antibodies that are pretty much destroying the platelets are called B cells. Rituximab destroys the B cells, so it stops you from making antibodies. Now, again, I'm not quite certain exactly when pediatricians would bring Rituximab into the mix, but that's something we would certainly consider in adults. So, and again, you could use Rituximab and L-Trombopag, because the thing about L-Trombopag and romiplostim is they're stimulating the production of platelets, whereas all the immunosuppressants, such as azathioprine, mycophenolate, Rituximab, prednisolone, they're suppressing the immune system and preventing you from making all the antibodies and all the other immune processes that are destroying the platelets. So that's why often in adults that are quite resistant to treatment, we'll tackle it in two ways. We'll give either romiplostim or L-Trombopag and an immunosuppressant. But in pediatrics, you know, these are certainly things you could discuss with your pediatrician, but exactly when they go into the pathway, I should be a little bit cautious about what I say, because it's probably a little bit different in younger people. Admittedly, I mean, your son is 14, so he's getting towards being an adult.
Yeah, that's the thing, and he's the size of an adult. He's 6'3".
So
he's not tiny. So I guess that's what the problem, well, their query would be, like what to do with the size that he is, you know, versus his age.
Yeah, I think I don't think that, I mean, he's not small, and I think that's it. You know, children are not little adults, but it sounds like he's on the maturer side in terms of he's got the height. You know, he's not small for his age. So certainly, I mean, I can't be certain, but I suspect he would be receiving adult doses of everything if he's 6'3". So whether a pediatrician would treat his immune system exactly as he would a 16, 17, 18-year-old, which is, you know, the youngest I see is 16, they probably would actually. But as I say, I always have to just be a little bit cautious what I say, because it's not where my expertise lies. But yeah, combinations, that may be the way they go.
Thank you.
Okay, Deborah, you know, was that okay? Yeah?
Yes, thanks.
Great stuff. Got a question from Liz. Interesting one, actually, given what's going on with COVID, etc. Now that ITP has actually been propelled into the searchlight, if you like, and you know, really in the limelight, could this have the positive effects of increasing the amount of research that is going on to actually find a cure for the condition?
Well, I think finding a cure for ITP is probably cure's an interesting word. Some people might be considered very cured if they're stable on, you know, 50 milligrams of L-Trombopag a day and their platelet count's been, you know, 200 for the last 6 years. Cure where you can just give a drug and a few months later you can stop that drug and the disease is gone, I think is a long way off for a lot of people. But having said that, I mean, you're all part of this group, so I may be speaking out of turn, but it may be that a lot of you have had quite a difficult journey with your ITP. But there are a lot of patients that I see who get ITP, they get a dose of prednisolone, they stop it after about two months, 10 weeks, and they're never affected again. So they have sort of been cured, but I haven't cured them. It's just that they've gone into remission. I think there has been a lot of research into ITP in terms of, obviously we have the new medications. I mean, they're not so new now, they're sort of 8 or 9 years old, but the fact that all that research was done and has given us romiplostim and L-Trombopag, I think has been fantastic. I certainly feel that a lot of my patients who were completely resistant to everything we threw at them, including splenectomy, and then, you know, I can think of one lady in particular who's had ITP for 25 years and was walking around with a platelet count of 10 and often had bleeding problems. She's now an L-Trombopag and has had a normal platelet count for sort of 6-7 years, and it's, you know, that's really helped. I think we've done a lot more work into quality of life with ITP. I think that, and I think that's not just ITP. I think that's a general move in the medical research world, that whenever you do a study, you're now looking at the quality of life and how that is improved, not just platelet counts or other parameters of the particular disease you're looking at. I do some research into ITP. I do run clinical trials of new drugs, but I'm not in a laboratory sort of doing, you know, basic science into ITP. But looking at the literature, a lot of that is going on, and I think some new medications are coming out because of that. You probably have heard of fostamatinib, for example, which now has a license in Scotland to be used as a second-line treatment for ITP, and avatrombopag is very similar to L-Trombopag, and may well be available in Scotland soon. So I'd like to think that ITP is in the spotlight. I think we've always got the problem, and I'm sure I said this at patient groups before, that we're not cancer, and it means we're not quite as sexy. But the more that the ITP Association, the more the UK ITP Forum can sort of promote ITP, then the more likely you are to stimulate interest and stimulate research.
Thank you very much for that, Catherine. Like, you know, the good thing is, even the last few years, there's been loads and loads of more treatments coming online, which is all added, like, you know, to the toolkit you've got available, isn't it? So
yeah, absolutely. Yeah. I mean, a lot of these drugs, people, you know, most patients with ITP will never have to use, because they are very much used as sort of 4th, 5th line treatments. But to have them available for those patients who are particularly resistant is incredibly helpful, because for some of them those drugs may work.
Okay, just looking at the chat again, there's a couple of people having problems with the sound. So if you do have a question, if you email me at info@itpsupport.org.uk, and we get someone to answer in the next couple of days. Okay, any other questions? Someone put their hand up. Right, Marlene.
Hi.
Lovely to see you, Marlene.
Yeah. Hi there. I can't believe I'm actually managing to do this. Really, my question would be about after splenectomy. I've had ITP for 12 years, and very much pushed along the lines of you need to spleen out, because various courses of penicillin worked but then waned. And I had 7 dreadful years of going up and down constantly. Couldn't get into any other treatments, was kept being told that this penicillin worked. That's all history. Anyway, I made up my mind I wanted 3 years after being on ex-penicillin after my splenectomy in 2016, which crossed fingers into the normal sort of levels of my platelets, but I had been thinking I wanted to get off penicillin, especially when I ended up in hospital a year and a half ago, because I had toothache, and I ended up with about 4 doses, 3 different types to 4 types of penicillin, because I had a long wait to get the tooth out, because The dentist wouldn't do it because I had ITP. I had to wait to be seen by the dental hospital. And during that time, I had various amounts of different antibiotics. And basically, I ended up in hospital with ITP. I didn't know, sorry, I ended up in hospital with COVID. Oh my God, I'm going mad here. With C. difficile. And I didn't know that you could get C. difficile from various types of antibiotics. I learned that. And I'm just wondering, can I ever get off the antibiotics? Because at the moment I'm thinking I need all the sort of protection I can get. Is it a bad time to look at getting, I know I have to discuss it with my consultant, but I'm throwing it out generally just for, you know, for information for people perhaps, and also for any thoughts.
Yeah, so when it comes to antibiotics and splenectomy, to prevent infection after splenectomy, the evidence is weak that it's helpful. So what's really important are the vaccines before you have your spleen taken out, the various vaccines, to get the flu vaccine every year, because then that prevents you from getting flu, which could lead to secondary bacterial infections. So that's the most important thing. And then the last thing I would say is, if you get an infection, seeking medical advice urgently. Those are the things that I strongly recommend to all my patients who have their spleen taken out. Now, penicillin, by most patients who've had their spleen taken out, is taken quite poorly. We know that. We know that when people are taking preventative medicines, that it can be hard to remember. You know, I know that if I had to take medicines twice a day, I would probably forget from time to time, particularly if I sort of feel, you know, what they're doing for me. If I was taking a tablet that made me feel better, then of course you're going to take it. But if you're taking it preventively, then often you don't take it. And the evidence for regular penicillin, although it makes logical sense, because we know that people who've had their spleens taken out are at higher risk of bacterial infections, particularly certain bacterial infections, that penicillin prophylaxis, penicillin in preventative doses may reduce that risk. So if you were to stop penicillin, it's probably the least worst thing you can do, if that makes sense, in terms of protecting yourself from that increased risk for infection that you have because you've had your spleen removed. Does that make sense?
Yes, but at a time like this.
Now, your haematologist may kill me for saying.
No.
Sorry, say again?
No, because I recognise Rhoda was saying.
Rhonda, yeah.
Has she had a splenectomy and came off antibiotics?
Yeah, I don't take them anymore. I had my splenectomy in 2000, and after a bit of trouble, I have maintained a reasonable platelet count, a normal platelet count, and I've had various consultants in that period of time. At first, they wanted me to take the penicillin, and I don't think at one point I was taking it very well. And one of the doctors said, well, it's no good taking it if you don't take the whole dose. You've got to take the whole dose or not, you know, it's not worth it. So I went back on taking the full dose. And then when I had a consultant, I said, you know, I definitely don't want to be taking this penicillin. And she said, you really must. And then I got a new consultant and I asked him again, and he said it's okay to stop taking it. But this was quite a few years down the line.
Yeah.
I don't take it anymore, but I do have emergency antibiotics. So if I should get some kind of illness, infection, suspect that I've got some kind of infection and I can't actually go to my doctor. It always happens on holiday, or, you know, on a Saturday and Sunday or a long weekend, you know. I only have taken them a few times in 21 years. So I think that's pretty good. And I usually do ask advice. I mean, when I was in Australia at one time, I went and consulted a pharmacist. And he said, well, I think you should take them, which I did. But, you know, I think it's like everything with the patient-doctor relationship. You know, you have to go and talk to your doctor about it and negotiate what is best for you. And I think that the things that are coming up in the chat there, especially with the baby, Rajnikant, I don't know if that's how you say your name, but you're asking a lot of questions about your baby. And, you know, apart from Baggy, you know, we're not medically qualified, and so we can't answer your questions. You really have to go to your doctor, a pediatrician, who is going to be able to tell you about all of that. And, you know, these are things that some kind of expert or some kind of person who has the knowledge needs to reply to. I mean, you have an awful lot of questions there. You have an awful lot of concerns. And I know that from what you're writing that you're very worried. And this is obviously a very emotional thing, having a young child who's got this problem.
I think Raj has now got his audio working because he couldn't get it working before. Raj, are you online?
Unmute.
No, he's not.
Yeah, okay. If you wanted to speak to us, you would have to unmute, but one of yours is unmuted. Anyway, I mean, the whole point.
Here he is.
Yeah, hi everyone.
Hello, did you hear anything I said?
Yes, now I can hear the audio. I have connected with a different PC.
Have you heard anything that I said?
No, I haven't heard anything. That is the reason I have changed the PC. And now my son is 23 months old, and he was diagnosed around 6 months back. He was having bleeding from the poop, and we took him to the hospital, and then it was diagnosed ITP. And that time the platelet count was 3,000 around, and then they gave the steroid and IVG also. And after that, it increased to around 30,000, and then it get decreased to below 10,000. So the doctor started the Dapsone 10 mg tablet, and the result was not really very good. So now he is on the Revolut 25 mg, but till date, last blood report count is 35,000. So this is the situation right now.
Okay, thanks, Raj. You also asked a question about does ITP or the effects of ITP affect the learning milestones of a child? And I'm sure that's not the case, but Catherine, could you just...
Yeah, I mean, as I said before, and I don't know if you could hear me before, Raj, but I am not a paediatric specialist. I only treat adults completely, and therefore only adults with ITP. So I really feel it's not appropriate for me to comment about developmental milestones in children with ITP. I see no reason why it would affect developmental milestones. But I need to be very careful what I say. You know, I'm here as a doctor giving expert advice, but I mustn't step outside my remit. So so I'm sorry about that. Hopefully your paediatric hematologist can answer a lot of the questions that you have. But obviously the patient association group, you know, can give you general support here this evening.
Yeah. Thanks,
Thank you, Catherine.
Yes, I have also discussed with my pediatric and also the hematologist also regarding the same things. He said actually he is not aware about that because the research is, they have not seen any research on below 2 years age of case. So he is also clueless on this. So that is the reason I'm looking for some of the research paper.
Okay.
Okay, so someone...
Thank you, Raj.
Someone's I don't know if I was Anthony or Tony, I don't know how you'll know. Raj has put up something in the chat about going to the IT Support Association website, and there's Dr. John Granger is a paediatric haematologist who specialises in ITP. So if you go to the ITP Support Association website, and that's actually Anthony's put the link there, itpsupport.org.uk, you may be able to just link in a bit more. I don't know, actually, Mervyn, is there a paediatric group? You see what I mean, where parents can go?
We did one, a virtual one last year with Nicola Cooper.
Right.
For Haverford, but basically it encompassed the whole country.
Right.
That was attended by about 40 or 50 people, and
yeah.
I know I'm actually in discussion at the moment with Nicola to try and do another one at some time. But there's lots going on, unfortunately.
Yeah. So Raj, maybe that's better to actually be involved in a group where paediatric specialty is there, and also there are parents of children with ITP. You might find that more supportive, possibly.
Yeah, like you also mentioned John Granger. I was talking with John earlier in the week. He would love to do one, but unfortunately he's normally a team of 3, and currently he's a team of 1. So his workload has gone through the roof. So but that is another option that we're working on. So yeah. Francis, you had your hand up earlier.
Yep, sorry, unmute. Yeah, I was actually coming on for what Marlene was saying about the antibiotics for a splenectomy. I had my spleen removed in 1996, so clearly before I was born. But that was in America, and the protocol there had nothing to do with antibiotics at all. It was get your pneumonia jab beforehand and do all of that, and that was it. And then I moved to Scotland in 2001, which will have been, gosh, not that long later. Anyhow, a few years later, I moved here and got set up with my GP and then a hematologist and nephrologist for all my various conditions. And they said, well, you need to be on antibiotics. And I said, no, I don't. And there was a bit of a back and forth, and I won. But the kind of negotiation that took place was that they would allow me to not take the antibiotics, but only if I carried with me an emergency high dose thing of antibiotics, and I took it if I had a fever above this, or I had this or that, or the next sort of symptom. And so I'd always carry that, but eventually it's like I've never taken it. So I've only actually taken antibiotics like twice, maybe in the last 20 years, because I just haven't been sick in the way that I would need antibiotics. Can't have antibiotics for virus sort of things. So it was all about advocating, and it comes back to an earlier thing about your specialist doesn't necessarily know if they're not an ITP specialist, or your GP. And when I moved, so I lived in Edinburgh, moved to Stirling, moved back to Edinburgh, and got a new GP. And every single time I would have any blood works done, she'd get it across the desk and they'd call me up panicked. You have a platelet count of 30. You must go to A&E. It's like, nah, don't worry about it. And it got the same thing when she sees my kidney function, because I've got kidney disease as well. But they've stopped because I've been able to educate them and say, no, calm down. This is what it is, to the point now where my doctors and my specialists included, because I have polycystic kidney disease in addition to my ITP and then the no spleen, and each of the specialists and the GP, they don't necessarily know what's going on. So it's always me educating them, but advocating, because they'll do what they think is best based on their kind of general practice. But like you'd said earlier, you've got baggy on your
I know,
I know that's not the
I
actual
know.
name.
It's Catherine. I'm sorry.
No, that's okay. I knew I caught it, but I didn't remember it. But it's all about the doctors have a set of protocols. That's what they're looking at, and they don't know you as an individual as well as you know you as an individual. And it's all that treating the patient-centered healthcare is part of the, sorry, I do health informatics, but it's all part of that thing now. And so it's just that advocating, no matter what it is, for every single step along the way. All I do is advocate in a non-confrontational way, not in a, look, I've gone to Google and this website scienceisn'treal.com says, you know.
I think, yeah.
Yeah.
It should always be a two-way conversation, always.
Yeah.
And there's something to be said, you know, we do, particularly in secondary care, so away from the GP world, we are often specialists. And so, you know, I don't know much about polycystic kidney disease, and probably your renal physician doesn't know much about ITP. So
no,
it's all
they
about
know more about it now.
and it's all about communicating between the two groups. And what I was going to say, because someone's got their hand up, what I was going to say is that this variation in antibiotic advice is because there's no evidence. That's you'll often see that as soon as there's no evidence, doctors are doing slightly different things. But one thing I should have said, as Rhonda picked up on, is that if you're not on, well, even if you are on preventative antibiotics, to have a supply of some form of antibiotic, different ones will be used. Some people use ciprofloxacin, some people might use higher dose penicillin. To have those antibiotics at home, particularly if you do suddenly think you might have developed a urinary infection on Saturday evening, to have those and be able to take those and then either go to A&E if you feel sicker, or to be able to see a doctor on the Monday morning and say, you know, I started taking the antibiotics because I wasn't feeling right. That, I think that's actually more important than taking preventative antibiotics.
Mm-hmm.
Absolutely.
But, you know, other haematologists might say the same thing, but I think most of us would say the evidence for preventative antibiotics is small.
Mm-hmm.
Okay.
Yeah, one point there, if I could just come in there for a moment. One point there that you brought up, which is very important, is that in different countries, they do have different guidelines. And so therefore, in America, they have never, ever recommended to take prophylactic antibiotics. They have always said, have your emergency antibiotics ready if you take ill. Whereas in this country, we do have the guidelines that say that it is better to take the antibiotics. However, you know, if you're a patient like me, who's had a splenectomy 21 years ago, you don't really want to have been taking antibiotics every day for 21 years. You know, it just doesn't seem sensible to me. And I am pretty healthy, even though I'm old. And I find that, you know, I can control my whole situation. And I can't underline enough that you must talk to your doctor. And if you're not getting on well with your specialist and you can't get the answers, and, you know, you need to be referred to somebody who is going to help you with that, then you must go to your GP and be really politely assertive, but say to them, look, you know, I'm really not happy. This is worrying me a great deal, that I don't feel that I'm actually getting the information that I need and getting the care that I need. And, you know, although I'm very grateful for everything you do for me, I really feel I need to see a specialist. And they usually come at that, especially if you've got a rare disease like ITP.
Okay, thank you, Rhonda. Liz, you've got your hand up?
Yeah, just a quick question. With the vaccine, the AstraZeneca one and possibly Janssen, they're saying that we have this rare ITP, drop in platelets, and these very unusual clots in certain veins in the body. What I'd like to know is, for clarification, is this a totally new disease that's related to the vaccine? And is it related to the ITP that we have in any way? And do these people that do survive, if they're treated after the vaccine and have this new phenomenon of low platelets and clots, do their platelets go back to normal?
So, wow, this has dominated my life for the last 5 weeks.
And I'm mixed up.
So I'll try and keep it brief, because we've only known about this for 4 to 5 weeks. And I go to meetings pretty much every day, and we are learning every day. So first thing I'll say is this is not ITP. Absolutely, completely different. It's not ITP. All the COVID vaccines are possibly associated with a slightly increased risk of new or relapsed ITP. But this thrombotic syndrome, which has many titles, but we're probably going to be sticking with vaccine-induced thrombosis and thrombocytopenic syndrome, otherwise known as VITS. And it is a very rare phenomenon. It only happens with the AstraZeneca vaccine, as far as we can tell to date. It only seems to happen with first dose, as far as we can tell to date. It appears to have a lot of similarities to a condition that we are aware of called heparin-induced thrombocytopenia, or HIT, but it is different because these patients have not been exposed to heparin. There are reports, even rarer reports, of what we call spontaneous HIT, where people in the past, prior to the AstraZeneca vaccine, could develop HIT without being exposed to heparin. So the best you can liken this to is sort of the spontaneous HIT that we've seen before. So you're sort of asking me if this is a brand new disease. Well, not exactly, but it's pretty new in terms of how you diagnose it and how you treat it. And that's why I've been able to recommend IVIG, or intravenous immunoglobulin, which I'm sure a lot of you have heard of because it's a common treatment in ITP. We know that that's very effective in this spontaneous HIT, and from the information we have to date, it appears to possibly help in this new condition. I'm not quite certain if I've answered all your questions, but it's definitely not ITP.
Do they get their platelets back to normal once they've gone through this?
As I say,
they'll come back to normal.
It's very, very early days, but platelets have gone back to normal, yes.
Right, so it's very different from our ITP because we're not going back to normal.
Yeah, I can't stress that enough. This is not ITP at all.
Thank you for the clarification.
Just so that it's really clear to the group, because I don't want you to get the wrong impression. ITP maybe is slightly increased risk of new ITP, relapsed ITP with any of the COVID vaccines. This VITS that I've talked about only happens with AstraZeneca and is completely different.
Thank you. I think in the media and in the press, when you read things, there's a lot of confusion, and sometimes I've read things and thought, oh, this is ITP with unusual clots, and so thank you. That's really clear, clarified that for me. Thank you.
Thank you, Liz. Catherine, am I right in saying that the level of instances of thrombosis from either the AstraZeneca or the Pfizer vaccine or the Moderna are very, very similar? The numbers? So
when first reports were coming out about thrombosis with any of the COVID vaccines, it is absolutely true that there's no, so we've talked about baseline risk of developing new or relapsed ITP may be slightly increased with all the COVID vaccines. The baseline risk of venous thrombosis with any of the vaccines is not higher than baseline. So in that way, there is no increased risk of thrombosis with the vaccines. However, there is this very rare phenomenon where you can develop very severe thrombosis with thrombocytopenia, which is incredibly rare. So it doesn't bring the baseline up higher than the normal, but it is a completely new phenomenon. And no risk factors for venous, the normal risk factors for thrombosis do not appear to be present in these patients who are getting this syndrome. It's completely random. And that's what a lot of the investigation is at the moment, is why these small number of patients are experiencing such a severe condition. There's a huge amount we don't know. As I say, we hadn't even heard of this 5 weeks ago.
Yeah. But the amount of thrombosis through in people who haven't had any vaccine is way higher, isn't it?
Huge. If you get COVID and you get admitted to hospital, your chance for venous thrombosis is about 1 in 3. Whereas at the moment we're reporting an incidence of thrombosis, this rare syndrome. Well, the latest official figure is 5 in a million. So now whether that changes, goes up, goes down, the MHRA, the regulatory body, and Public Health England, Public Health Scotland, the Joint Committee of Vaccine Immunisation, this is being watched so carefully. Okay. So the risk of thrombosis with COVID completely outweighs the risk of this vaccine-associated syndrome. So again, I know this is an ITP session, but I think it's really important that everyone knows that this is a very, very rare phenomenon, and we still strongly recommend vaccination for everybody. So whichever vaccine,
precisely what we've been, the advice we've been given.
Yeah,
precisely that. I know time's getting on. Tina, you got your hand up?
Yeah, thank you. I just wondered if I could ask you quickly about Rituximab. You mentioned that it attacks B cells, so would that stop antibodies that you've just been vaccinated with?
Very, very interesting question. So if patients who can wait for Rituximab, we recommend you get a vaccine, but let's talk about COVID. You get the COVID vaccine before you get Rituximab, because then you've got all your B cells and everything, they're all working, you can have your response to the vaccine and then get Rituximab after you've had your second dose. Some people can't wait, so some people might need to have Rituximab before they get the COVID vaccine. I had a patient who was particularly ill with a particular hematological condition, and I had to give Rituximab before he got his vaccine. And obviously then that's a tricky situation, because you've suppressed the immune system of that patient and they haven't had a vaccine yet. And now you're in that horrible situation that we were talking about before, where your immune system suppressed and therefore you're at increased risk of COVID, but you may not respond as well to the vaccine. So the current guidance is, I'm afraid based on no evidence at all, but the current evidence is it actually comes from the Rheumatology Society. So rheumatology often will use Rituximab in a very similar way to how we use it in hematology. So you're not treating cancer with it, you're treating it more a sort of autoimmune condition. So an immune condition where patients are sort of breaking down, in ITP platelets when they shouldn't do. So the recommendation is waiting at least 4 to 8 weeks after the last dose of Rituximab before getting your vaccine, in the hope that some of your B cells have started to come back and you've got some capacity. Now, we know B cells generally don't come back in their entirety for a year after finishing Rituximab. So, your immune response to the vaccine is not going to be as good, but it's generally thought, well, if we wait about a month to 2 months, hopefully we'll give this patient who is more prone to getting COVID and having more serious disease some protection with the vaccine.
Could I come back with a sort of ancillary to that? So if you've had your second COVID jab, should you then wait before you start Rituximab?
So it's recommended to wait 4 weeks after the second dose of the vaccine before getting Rituximab. That's the current recommendation, because you hope that you've had most of your immune responses by then. You probably heard in media, or you may have been given advice by your GP, that generally you've got pretty good immunity by 2 weeks after the first dose. So that's why they're saying wait 4 weeks. They're thinking, most of the immune response to the vaccine has happened by 4 weeks after the second dose.
Lovely. Thank you very much indeed.
Thank you, Tina. Liz, you got your hand up still? Was that from before?
Oh.
Legacy hand.
Yeah.
There's always one, Liz. There's always one.
Legacy hand.
I don't know how to put it down.
That's okay. That's okay.
Thank you, though.
Any other questions? Because I know time's getting on. Patricia. You're on mute, Patricia. Go ahead.
Yeah, in a few days' time, I got to have my IVIG for my ITP, but I had to have a negative test result before they allow me in the clinic to have it done. And the problem continues that I also have to travel, and a month after my first vaccine, I had a test and I was positive COVID. And now I find out that that positive result, if I get tested again, it can keep being positive up to 90 days. Now, my dilemma is on this attestation form, I can say either I have received a negative pre-departure test from COVID-19, or I attest that I have recovered from COVID-19 in the last 3 months, which is 90 days, after having previously been tested positive for SARS-CoV-2 and have been cleared for travel by a licensed healthcare provider. Now, I'm having a problem having someone actually sign that I am recovered. And I'm scared stiff to have another test, because if I would turn up positive again, then what happens? Another 120 days, 90 days of being positive. So I don't know what to do.
So again, I have to say, this isn't my area of expertise. I'm very aware that once you've had a positive test, it can remain positive for a while. And certainly from a clinical point of view, in a clinic, you know, so patients who come up to have surgery or come to a clinic where they're going to be on a day unit and have to get a negative test beforehand, I can't remember the specifics, but there's certainly something along the lines that if you've been positive once, after a certain period of time, I don't know if it's 2 weeks, if it's still positive, that's okay, because we know that you've had the infection and that acute period is over. I feel I don't have expertise in this area. I'm not quite certain what this means going forward. Were you mentioning that you're going abroad and you need to have a negative test?
Yes. You see, my first vaccination was in January. A month later, I was positive. So that's 2 months ago now. And then I'm supposed to go abroad in 2 weeks for important reasons, legal reasons.
So I presume places to go to get advice would be NHS Inform. So that has everything. I don't know if you've been to NHS Inform already, the website, but that has everything you could possibly want to ask about COVID and COVID vaccination. That might be able to help, because I just don't know what travel companies or airlines do if you've got a persistently positive COVID PCR test, which you may do. I don't have the answer, I'm afraid.
I called 119 and they said that the physician has to document that I'm recovered, but I'm having a hard time. My physician at the clinic, they say, oh no, we're not going to sign anything that shows that you have a positive test. But the airlines say, one of their answers is that I have had a positive test, and they will allow that as long as the doctor says I'm recovered.
Yeah, I think the GPs are probably the best practitioners to be doing this. And I think if it were me in being a GP, I would simply have to say, this was the date of this lady's first positive COVID PCR test. And that date should be enough to convince anyone that you're recovered. But I really can't advise more than that. I'm sorry. I'd be speaking out of turn because I just don't have the information about what to do. But I am fully aware that positivity can remain for a long time.
That is tricky, isn't it? Yeah,
it is tricky. It is tricky.
Are you going to America again, Patricia?
Yes, I am.
Okay.
I haven't been back.
Okay, oh dear. Months. Okay. Any other questions, anyone, before we close? Marlene?
Could I just add an addendum, which I felt was quite important at the time. I did have I think it was amoxicillin as my emergency one, which I was advised at a weekend with the toothache to take. and then it went into medical, then it went into dental hands, and it was a mixture of the two disciplines. I just felt afterwards that somewhere along the line, when you move from one discipline to another discipline, the medical to the dental, maybe somewhere in there was maybe not the thought of something arising from too many medications. Anyway, that was just my thoughts at the end of the day. Yeah. That might have been somewhere in the mix.
I think, yeah, I think as doctors, or not just doctors, nurses, all healthcare professionals, when you're working across specialities, there has to be excellent communication. So I work in haemophilia as well, so people with bleeding disorders, and we spend our entire lives speaking to other medical professions, so dentistry, orthopedic surgery, and it's that communication that's essential to safe patient care, with us all appreciating that, you know, I don't know how to fix a hip and my orthopedic surgeon doesn't know how to treat haemophilia. So it's communication. In fact, I gave a lecture to some dentists yesterday and I learned a huge amount about dentistry and they learned a huge amount about haemophilia. And we both agreed, it was actually on the last slide, it's all about communication. So that is what all your doctors should be doing.
Thank you. And thank you
very much, Marlene. Thank you, Catherine. If that's it, we call a close. Anthony, last one.
Yeah, it's just a very quick reminder, really, and a plug for the annual convention. If people haven't heard about it or read about it yet, it's on the 8th and 9th of May, Saturday and Sunday. We've got a huge agenda to get through on both days. There's pretty much something for everybody that's ever heard of ITP across those 2 days. So if you can join us, it's open and available to anyone, anywhere, with any interest in ITP. You can register for it free of charge on the website. So if you just go along to the website, you can do your registering on there in good time, but you won't be admitted unless you have pre-registered. So just to give everybody the heads up there.
Just on that, Anthony beat me to it. I was just going to say about registering. That's okay, mate. And I got the figures today for how many people we've already got registered. We've got over 450 already registered for this convention, which is outstanding, really outstanding. So, okay, Tina?
Didn't it say on the Health Unlocked website that if you registered last year, you don't need to register this year?
That's correct, yeah.
Thank you very much.
Just double check that your login details are okay, because you'll be amazed how many people forget what the login details are. And then they give me an email saying, can you help? And I can't help 400. So, yeah. Okay. Well, thank you, everyone. Thank you in particular to Catherine. Thank you, Dr. Baggett. It's been very, very useful. Thank you, Rhonda. Thank you, Anthony. Thank you all for contributing. It's been a really excellent meeting. I will post a recording of this up on a YouTube page in the next day or so. Thank you very much. Take care, everyone.
Bye-bye. Bye-bye.
Thank you. Bye. Bye. Bye.